to the LAM Foundation's the LAM Powering LAM Research webinar here. We're so excited to have such a great group of people joining us for this event. Before we get started, just a couple of reminders. First of all, registration for the 2020 Lamposium is now open. If you have questions or need assistance with registering, please call the LAM office, 513-777-6889. Slide. Another reminder is to please, anybody who's calling in or using some other way to get into the webinar, mute your microphones so we don't have a lot of feedback during the webinar. Slide. And if you have questions during Dr. McCormick's slide presentation, please type your question in the event of your screen. Jim will be posed to Dr. McCormick at the end of the presentation if we have time. Slide. So 2020 marks the 25th anniversary of the inception of the LAM Foundation. We begin this year's celebration by recognizing how women with LAM support one another and share both knowledge and power. This power has had the force and strength to drive life-changing outcomes through LAM research. As we will hear this evening, power is also needed for a clinic to produce meaningful results. Clinical trials are necessary to bring new advances from the bench to the bedside. Innovative scientific advances are possible because patients and healthy individuals participate in clinical trials to help provide answers about safety and effectiveness of treatments. Our clinical trials need LAM patient participation to power our LAM research. The LAM Foundation's core mission is to fund the most promising research. This is evidenced by the fact that the foundation has raised more than $26 million in 24 years. 60% of this has been dedicated to scientific initiatives. Tonight, we're very fortunate to have Dr. Frank McCormick presenting Powering LAM Research. Dr. McCormick is the director of the Division of Pulmonary and Critical Care Medicine at the University of Cincinnati Medical Center in Cincinnati, Ohio. Dr. McCormick has been the scientific director of the LAM Foundation for 25 years. Thank you for being with us tonight, Dr. McCormick. We'll turn the presentation over to you now.
Thanks so much, Mary Sue. Is everyone able to hear me?
Yes.
Great. Okay. Well, thank you everyone who's joined us this evening for giving us a little bit of time to tell you about all the exciting advances in LAM research. And I'll be focusing on the things that are most exciting to me, and hopefully you'll feel the same way. I'll start with a general introduction about LAM for people who may be new to the subject. First slide, please. Let's see, I'm having a little bit of a video problem here. I'm not seeing any slides. Mary Sue, can you tell me, is there a problem with presenting the?
Do you have a slide up on your slide that says LAM is rich?
No, I have a slide up that says LAM Research Webinar, and it's got 3 panels.
I'll get a hold of Rosalie here.
Now I do.
Okay.
Okay, thank you. So start just by recounting some of the wonderful things that have happened in LAM over the last 25 years. We have an effective suppressive therapy that's approved in 40 countries. We have a diagnostic test that spares many the need for biopsy. We have international guidelines for management, which is uncommon among the rare disease group that with similar numbers of patients. A worldwide network of expert LAM clinics, a registry and a tissue bank, community of talented clinicians and scientists working on LAM in their laboratories and clinics, organized, informed, motivated patient community, exceptional patient advocacy organization, very valuable partnerships with the Tuberous Sclerosis Alliance, the NIH, and the Rare Lung Disease Consortium. One of the longest running intramural NIH programs in history. Sorry, I lost the slide there.
It's still up on my screen.
Now it's up again on mine. A rich understanding of the molecular basis of a disease and 15 complete open or pending trials, which is remarkable for a disease that affects 5 women per million. Next slide, please. Seems like we're having some technical difficulties. I'm sorry, everyone. See the first slide now. Next slide, please. All right, well, we'll try this. I see a slide on my screen that describes the fact that LAM cells make factors like VEGF-D that induce tissues around them to produce lymphatic channels so that they can gain access to the lymphatic network, which is a strategy that LAM cells to move to new places. So we think that LAM starts somewhere else other than the lung and then finds its way into circulation, in part by making lymphatic channels around the cells so that they can move in the stream and gain access to the lung. These pictures show LAM cells staining with antibodies against VEGF-D and to the receptor for VEGF-D on the surface of the lymphatic channels. Next slide, please. This slide has not changed. I still see the VEGF-D slide, the one I just described. So now I see the next slide, which depicts the lymphatic system. The You can see that our limbs and the abdomen contain these tiny vessels that wick up extra fluids from our tissues and return them to the venous system. And we think that LAM cells, which develop in a peripheral tissue, we don't know where, we'll talk a little bit more about that, lose control over their growth, make lymphatic channels around them, find their way into this system, and then are transported to the lung where they do their damage. Next slide. So I mentioned that LAM cells produce VEGF-D, this lymphatic growth factor that induces lymphatic vessels around them. And you can see here on this slide, excuse me one second. Serum VEGF-D is produced by LAM cells and it becomes elevated in the serum. And that distinguishes it from other lung diseases that can look like LAM. So here you see below 3 CAT scans of cystic lung diseases that can mimic LAM, but none of them have elevations in serum VEGF-D. So we can use that marker as an index or a diagnostic marker to help us make the diagnosis of LAM in cases that where we're not absolutely sure based on the CT alone. So this is an example where LAM cells are making a factor that helps them gain access to the lung, but it can also be used to our advantage to make the diagnosis, and also, as I'll show you, to help determine which patients are more likely to progress and which are more likely to respond. Next slide, please. Next slide, please. Rosalie, I can see this, the same slide I just described is still in front of me. So what causes LAM? This slide is a depiction of what we think is happening sorry, I'm trying to very sorry for these technical difficulties. I'm still seeing the first, there we go. Slide change now. So down in the left-hand corner, you see a woman depicted and a LAM cell that's arising from somewhere in the body that finds its way into the lung, into this space between cells in the lung that form the air sacs. And once in that location, LAM cells secrete factors that degrade the matrix of the lung and form these cystic spaces on the bottom right, which contrast to a normal lung structure shown on the upper left. The LAM cells originate somewhere else in the body, move to the lungs, secrete factors that dissolve lung tissue and remodel it and form cystic structures. Next slide, please. Afraid something's happened to the formatting of this slide, but it was meant to show that first clue we had that LAM cells arose somewhere else in the body rather than in the lung itself was that LAM recurred in the lungs of transplanted patients. And when the genetic genetic origins of the cell in the lung were tested, they were found to have arisen from the recipient, suggesting that LAM cells were migrating from the body of the person who received the transplant into the organ into the transplanted organ of that patient. And that was proven genetically by Dr. Henske now many years ago. Next slide, please. Sue, I'm afraid that this is just not going to work tonight because because of the technical difficulties we're having.
Frank, can you hear me?
Yes.
Okay. Yeah, very sorry. We must be having some timing issues where most of us are seeing your slides, but unfortunately they're not changing for you, which makes it a difficult presentation. Do you want to talk in general about LAM science and research and some of the exciting developments that are happening right now? And we can do this a little extemporaneously since we have 132 people listening.
Sure. Yeah, be happy to do that. So turn off my electronics here. So the things I wanted to tell you about that are new in LAM that I find very exciting. I'm going to focus on three separate categories. One is this new finding from lung tissue from people who have had lung transplant, that we may understand more about the origin of the cells that migrate into the lung in LAM. So we had had the opportunity with help from the LAM Foundation to obtain explanted lungs from 4 patients who generously donated their lungs at the time of transplant. In a group of about 20 investigators at Cincinnati Children's and the University of Cincinnati received these tissues and processed them, did a special form of testing called single-cell RNA sequencing. And what that means is that these transplanted lungs were divided into smaller pieces and then dissolved so that into separate cells, so that a bouillon cube piece size of lung has millions and millions of cells in it, and they can be separated into individual cells and then individually sequenced. So we take about a sample of about 10,000 of cells from an explanted lung and individually sequence each of about 4,000 genes in each of those 10,000 cells. And each of those signatures, gene signatures of each cell, tells us where that cell came from. So we can see that the cells that line the airways, which are called epithelial cells, have a certain signature, and they all belong together. And we can put them in a little cluster and set them aside, say on a piece of paper, and say these are the epithelial cells. We can do the same with the endothelial cells. We can do this with the immune cells. And when we did this with the LAM lungs and compared them to normal lungs, there was a population of cells there that were not present in the normal lung. There weren't very many of them, maybe about 100 of these cells that clearly didn't belong in the lung. And they were making the things we expected they should be making for LAM. They were making VEGF-D. They were making the target for the HMB45 antibody that most everyone has heard about, that is helpful for diagnosis of LAM, but was also found in this cluster of cells that emerged from the single cell sequencing of the LAM lung. And there were 10 or so other markers that we absolutely expected to be expressed in these LAM cells, but there were also hundreds of other new proteins that were being made that we had no idea LAM cells were making. And they provide fantastic insights into what LAM cells are doing in the lung, what they're doing to other cells around them, what they're doing to the lung tissue in terms of dissolving it, and also what organ system those cells look most like. So you can take the signature of those 100 LAM cells, compare them to the signatures of, say, the heart and the intestines and the kidney and the uterus and lymphatics, and you can ask the question, which organ do these cells look most like? And the idea was that maybe we could get some insights into where they were coming from. And it turns out that they look most like the uterus, with a very powerful uterine signature. And that is an absolutely phenomenal finding. It doesn't prove that those cells are from the uterus. It doesn't absolutely prove it. It's the best evidence to date. This is something we'd suspected in the past because LAM is so restricted to female gender. And we know from case reports that many patients have been found to have LAM only in the uterus or in the uterus and the lung. It turns out that proving that LAM cells move from the uterus to the lung is not as simple as you might think, but this finding in the lung really rekindled this whole idea that maybe LAM cells are coming from the uterus. And the other possibility that we have to consider is that maybe the mutation in LAM cells is driving a genetic signature that's mimicking a uterine signature, that it's lying to us in a way. And that's the possibility that we have to address through future experimentation. But as it stands now, we're all very excited about this concept that we may understand something about where the LAM cell comes from. And why does that matter? Why does it matter where it's coming from? Well, it matters because it changes the way we might think about treating it. There are lots of therapies for uterine fibroids and uterine growths that we might be thinking about now that this information came out about LAM cells looking like uterus. And also when we're making animal models, we have to know what cell to target with our genetic strategies. So if we want to make a change in a LAM cell, we have to know what kind of cell it is and what kind of promoter we call it, how to drive that gene in a particular cell. So this gives us some guidance about future LAM model design. We may want to think more closely about targeting the uterus in our model design, and that's something that Dr. Hammes had done in his research. So there's a team of about 20 people working on this at Children's and University, and it includes Jane Yu and Jan Zhu and Jeff Whitsitt and Catherine Wickenheiser-Brokamp and Nishant Gupta and many others. And we've designed a lot of the upcoming LAM symposium around the concept that we should dig more deeply into this possible connection to the uterus, and there are many uterine experts coming to that meeting. So,
can you hear me?
Yes.
May I ask a question?
You can.
Well, in talking with you and these scientists that you just mentioned, and knowing that we're going to be focusing on this at Lymposium, one of the things I've heard them say is by listening to these cells and listening how they're talking to each other and what's happening in the lung. Can you speak a little bit to that? It was very fascinating.
Yeah, so that's right. So when we're doing this gene analysis, we can ask what are the LAM cells making? We can also say, what are the cells next to them making that allows them to hear what the LAM cells are trying to say? Those are receptors on cells such as epithelial cells and immune cells. And you may or may not be aware that if you take a LAM spot in the lung and you microdissect out the cells in that spot, only a small fraction of them have the LAM mutation in them. The LAM cells are sending out signals inviting other cells to come in. And those cells are making things that are destructive. So it may be that this destructive process in the lung isn't necessarily coming directly from the LAM cell. The LAM cells may be bringing in other cells that can hear the signals they're making, and they're the cells that are doing the damage. And that's very important to understand because it changes the way you think about targeting that process. So Sue's rightly pointing out that we're learning about both the signals coming from LAM cells and who's listening to those signals within the lung and outside the lung, because the lung also recruits circulating blood cells to come in and join the party. And some of those cells can inflict damage, such as lymphocytes and other kinds of immune cells can sometimes get a little bit overzealous and cause more damage than benefit. And that process can get out of control. And in some cancers, we target that process, the inflammatory process. So we're learning a lot from this single cell besides just what LAM cells are making.
Go ahead. So you said you started with the single cell, which is very exciting. And of course, our whole theme tonight is the power of clinical trials and the power of women with LAM. And many of our women had donated lung tissue as well as other surgical tissues. But I think you were going to go on and talk about other things you're excited about related to LAM research.
Right, and that's a good point. I did want to emphasize how important it was that LAM patients on the busiest day of their life during their lung transplant, they made sure that the tissue got to us with the help of the LAM Foundation so that these studies could be done, because we would be nowhere without them. There aren't great animal models for LAM, and the only good model for LAM is the human model, both in trials and in our studies of trying to figure out how LAM is, what the pathogenesis of LAM or what's causing the damage in LAM. So we're very grateful to the patients who were able to both go through a very big surgery and on that same day get this tissue to us.
And you've looked at other organs as well, right?
Right. So we heard about the time that we understood that the cells in the lung were telling us that they looked like they were coming from the uterus. There was a LAM patient in Indiana who was having a hysterectomy, and she let us know about it, and we were able to actually send someone on a 2-hour drive to pick that tissue up, bring it back to Cincinnati, and look into that uterine sample for evidence of LAM cells in the uterus. And in fact, indeed, the uterus had a lot of LAM cells in it that had the same signature that we saw in the LAM cells in the lung. And it so happened that we had a prior lung biopsy from that patient, and we could do genetic analysis on the LAM cells in both the lung and the uterus, and found that the same genetic defect in tuberous sclerosis 2, TSC2, was present in the lung tissue and the uterine tissue from that patient. And that's another piece of evidence that they're arising from the same source. And it, to us, the most likely possibility of all is that it arises in the uterus and moves to the lung. But we also have to consider the possibility that there's an outside source that's populating both organs. So it's still a work in progress, but we feel like we've made a major leap forward, and we're all very excited about this. Another area that I'm very excited about on the therapeutic side is the idea of immune checkpoint inhibitors. And many of you have heard about this in other types of cancers, that there are strategies for unleashing the immune system on cells that are not supposed to be there. These cells are cancer. I'm going to use the analogy of cancer here, but cancer cells are smart enough to make things that convince the immune system, the immune cells in the body, to leave them alone. They send out these signals through proteins on their surface that they're innocent. Don't kill me, basically.
Smart.
Yeah, it's very smart. And it is, these new checkpoint inhibitors basically interrupt that defense of cancer cells. They turn it off so that the cancer cell can no longer tell the immune cell that it's innocent, and the immune cell recognizes it as something foreign. And that's very exciting. It's produced unbelievable improvements in a variety of cancers, and I know almost everyone has heard about this. It's all the rage in the cancer field now, and it may well apply to LAM. There are some mouse experiments that suggest that this system may be targetable in LAM as well. And it has not yet been trialed in people. It is a therapy that has considerable potential side effects, so we have to do this very carefully, because LAM is a very slow-moving thing. And most of the cancers that this strategy has been applied to have been things that are much more rapidly, progressive. So it's important to be, move slowly, do this carefully, and make sure we design experiments in a way where we can assess benefit without doing harm. So that's an area I think everyone's very excited about. And the Lisa Hensky lab and the Vera Krumskaya lab are working hard on those strategies.
And they will both be at Lamposium with their colleagues to talk more about this topic.
Yes. We do have
with the patient.
Sessions that will be focusing on this area. So that's
very
second.
Exciting.
It is very exciting. And there's a third area that I'm excited about, and that's this idea of metabolic targeting. So LAM cells, as everyone knows, when the tuberous sclerosis proteins are mutated in LAM, mTOR is activated. And that's why mTOR inhibitors are effective suppressive therapies. And mTOR is a switch that tells the cell when to grow and when not to grow. And it does that. mTOR knows when it's time to grow because it has sensors for when there are enough nutrients around or when there's enough space to divide. The cell knows how to regulate its division and growth. And mTOR is the node through which all of those signals flow. When it's mutated, there's a constant signal to grow. And that results in excess DNA synthesis and synthesis of many other molecules that are needed to grow and divide. But DNA synthesis is quite targetable. So if you have a lot of cells in an organ that are quiescent, that are just very quiet and not dividing or growing and not making much DNA, and you have LAM cells among them that are making a lot of DNA because mTOR is activated and telling the cell to grow, that's a targetable Achilles heel, if you will. I mean, we can feed those cells a bad building block for DNA, basically a nucleotide that has a change that gets incorporated into the DNA that's being made and makes the cell sick and ultimately causes it to die. So that's called metabolic targeting, and LAM cells are targetable because they're making a lot of DNA. This emerged from experiments in many labs, but predominantly in Boston and Brendan Manning's lab. It turns out that even a decade ago, that there was a hint from an experiment done at the National Institutes of Health that one of these bad building blocks, methotrexate, was active against LAM cells, and nobody thought that made any sense. But now, 10 years later, there's been so much discovered about what mTOR is doing in the cell, what role it plays in cell division, cell growth, and making all of the things that are needed for a cell to proliferate, including proteins and lipids and DNA. And because of that knowledge, we now understand why that hit 10 years ago makes sense and why this is a promising direction going forward. So the drug that worked the best in the laboratory was something called mesorbine, and it's a kind of nucleotide, or bad nucleotide building block, if you will, that is actually in use in Asia, and but it's not available in the United States. And we've been trying to convince some of our Asian partners to think about trials, at least small pilot trials with that drug in China. And there are analogs that we might consider trying in the United States. That's another direction that I think is incredibly promising in LAM research going forward. I wanted to talk a little bit about mild, but Sue, did you have anything else you wanted to ask me about those three topics?
No, I was just scanning the questions, and I think most of them we can get to towards the end, but those three areas are extremely exciting in terms of new methods of getting at LAM from other directions, and I think that should provide everyone with a lot of hope and all of their efforts in propelling this forward. So yeah, we'd love to hear about mild and the importance of this study.
Right, so and I know many of you have heard about this, but I think it's important that we reemphasize how critical this particular study is to the future of LAM treatment. And I think that what we've learned from miles is that it's an effective suppressive therapy. It works in most, but not all patients with LAM. Most patients enjoy stability when they're on sirolimus. Bad part of it is that it's a drug that you have to take indefinitely, and we're working on strategies for drugs that can be used to induce remission and kill LAM cells so that therapy could stop after the LAM cells are gone. That's another area that we might talk about if we have a little time at the end. But until we have those remission-inducing therapies, we really need to fully understand how to use this therapy that we have in hand, and we're all very lucky to have. And what we do know about it is that if we start the drug when people have advanced LAM, that it stabilizes disease. Most of the patients who enrolled in the mild trial had about 50% of normal lung function. What we don't know is when to start it in someone who's got milder LAM. It would make a lot of sense to me that if we started earlier, perhaps we could arrest the disease stage where there's much less damage to the lung. The question really becomes, is it safe to take for longer periods under that paradigm? So the mild trial is basically miles all over again, except that we're using a low dose of sirolimus. We're randomizing people to receive either sirolimus or placebo. We're only enrolling people who have normal lung function, that is an FEV1 of greater than 70% of predicted. And we're following these two groups, those on sirolimus, those on placebo, over the course of 8 visits in 2 years to see if the drug can be used to stop the disease in its tracks when it's in very early stages. You might consider that maybe we should just go ahead and start doing that. But the fact is the drug has side effects, and many physicians and many patients who feel well don't want to start the drug until they're further along. But we don't use that strategy in many types of disease, like high blood pressure or diabetes. We don't wait until there's damage to start the drug. We'd like to start the drug at an early stage and keep it there. So our hope is that if we can fully enroll this trial, we can answer that question. And Susan McMahon at the University of Cincinnati, who's my coordinator, has been working very hard trying to get the trial fully enrolled. And she's up to about 38 patients enrolled out of the 60 that we need. That means 22 more patients would need to enroll. And we're looking for people who have normal lung function, FEV1 greater than 70%, who are not currently taking sirolimus. You can have taken it in the past, and who are interested in being screened or considering enrolling in the trial. We'd love to talk to anyone who's in that category and who has the time and the interest in participating in the trial, so that we can answer this question once and for all, just as we all did together for Miles. This is our chance, maybe our last chance, to answer the question about whether we should be treating virtually every LAM patient at the time of diagnosis, so that we can keep the disease arrested at an early stage. So,
yeah. So to reiterate, we have this drug that works. The way we use it now typically is to wait until someone has declined to a certain level. And our question is, might someone with 90 or 100% lung function sustain that if we could start the drug early at a low dose? And in this trial, you're at 38 out of a total need of 60 people. And that is the question of power. Can you talk a little bit about the definition of power and why it's important?
Right. To prove something statistically in a trial, we can predict the number of patients that would be needed to answer the question based on what we understand about the disease and what we've learned from prior trials. And before we started this trial, we had our statisticians do the math, and they concluded that 60 patients should be able to answer this question. And if we don't achieve the target, it will fall short and may not be able to prove that the drug works. We'll learn some things about safety, and we'll learn some things about LAM itself, but we won't be able to answer the question about whether or not it's a good idea to start it early in the disease at a low dose. We kind of ended up in that pickle with the TRAIL trial. We didn't fully enroll that trial. The trial in England called TESTIL for LAM did not fully enroll.
Mm-hmm.
So there have been a number of trials that have not reached the point to where they were powered to answer the question they were designed for.
Got it. Right. So getting closer to that 60 resolves some of those problems.
Yes. Right. So
can you talk a little bit about what are some of the why it's difficult to enroll, or what are some of the things that Susan would ask someone?
That's a very good question. Susan's very diligent about this, and she's talked to hundreds of potential candidates on the phone. And it boils down to whether people have the time to travel to a study site. In many cases, the patients feel well. They don't know whether they hope to receive the placebo or the drug in some cases. So it's also the enrollment criteria are a little bit complicated, because we need to have subjects who have enough LAM that we think it's plausible that they would progress. And that was very hard to design eligibility criteria for. So, for example, to enroll in this trial, you either have to have a certain rate of decline, which has been documented on prior PFTs, or some form of an oxygen requirement, either with sleep or with exercise, usually. Those are two top level criteria. If you don't meet either of those, there are other criteria. If you're premenopausal and you have other abnormalities on your lung function tests other than FEV1, such as your diffusing capacity or your residual volume, or you have a problem with oxygen dropping when you walk, do a 6-minute walk, or you have a certain number of cysts on your CAT scan, you have to have some evidence that there's enough LAM present that it's plausible that you might progress. Because that's exactly the question we want to try to answer is, if you're a clinician in Kansas and someone presents to you with early LAM, do you start them on the drug or not? And most of us use our judgment about how likely it is someone's going to progress. And we want to be sure we enroll people that most clinicians would at least consider starting the drug in. And then secondly, if you're postmenopausal, just to finish the eligibility criteria, you can still enroll without a prior history of decline or without an oxygen requirement of any kind if your VEGF-D is greater than 600 and you have any of those other lung function abnormalities like diffusing capacity that's abnormal or residual volume that's abnormal, or your oxygen content drops when you walk, or you have more than 20 cysts at the carina on your CT. So it's very complicated to keep all that in one's head, and that's why we ask people who might be interested just to call Susan and walk through it with her and see if you might be eligible.
Great. There's good information on the website with how to get a hold of Susan. I don't know if you can see, we have this entire line of women with LAM who are talking to each other about this study, and lots of really good questions and support for each other. One of the things they're asking about is what happens when someone finishes the 2 years on the trial. Do they stay on the drug? What do they do next?
That's a very good question. At the end of the study, they are able to learn whether they were on placebo or drug, and they're certainly welcome to talk to their clinician about starting on the drug if that's the decision they've come to over the course of the trial, with the knowledge of what they were on before, or to go on without therapy. Half the patients will have been on placebo during that period, and they may say, my lung function's still stable, I feel fine, I don't really want to consider taking the drug. So the trial doesn't provide for drug after the 2-year period, but it will provide you with the information about what you were on so that you can make a decision about what you'd like to do going forward, you and your clinician.
And you'll have 2 years of excellent information about your health and your progression, and better to make decisions with.
That's right.
Right.
And I have 10 minutes, so I wanted to talk about a little tiny bit about Midas, but also about these new possible approaches to determining LAM burden in the body that we've got some exciting information
Imaging.
about. Yes.
Mm-hmm.
So just a little bit about Midas. And Midas is this observational study where we're collecting information in a population-based way. That is, these aren't people who are flying to the NIH necessarily. These are people who are just going to their local LAM clinic, and we're tracking their course of disease and their response to sirolimus and how many side effects they're having on sirolimus. And we're trying to understand the natural history of the disease in its natural state. And we're going to use that information to help get drugs approved. For instance, this information is being used to get sirolimus approved for LAM in the EU. And it's going to be used to help us understand sirolimus side effects we may not have anticipated. Many of you may be aware that sirolimus is known now to cause cysts in the ovary, and maybe to have cysts persist in the ovary, which can raise alarm with an OB-GYN physician. But if one is informed that sirolimus can do this, and that it can be observed without any kind of intervention, that puts everyone's mind at ease. So we find things that help us take better care of patients with LAM and understand the side effects that might be expected from this drug. one of the other things we're really curious about is that about 30% of patients with LAM have symptoms, lung symptoms that cycle with their menstrual period. So they feel their chest tightness and discomfort, usually just about the time of the period that lasts for 2 or 3 days. And we're wondering if that's trying to tell us something about whether LAM is likely to respond or whether LAM is likely to progress. And we can use this mechanism through Midas to do that. We're also providing spirometers, home spirometers to some patients in many of our studies, measure lung function at home. So in the case of this menstrual cycling of symptoms, we could send people home with a spirometer and understand, in addition to symptoms, do they have objective changes in lung function over the course of the menstrual cycle? So it's going to be a very powerful tool to help us enroll trials in the future. For instance, inhaled sirolimus is probably coming this way in the next few years. Inhaled sirolimus is an appealing strategy for people who have side effects that they found troubling. Some people have problems with GI side effects or swelling in the ankles or acne, and all of those things may do better with a drug that's deposited exactly where it's supposed to act. So I think it makes a lot of sense. It's been through some phase 1 and phase 2 trials already, and it seems to be well tolerated. And I think this Midas registry and the LAM Foundation is going to make it much easier to do these trials as they come, as these companies come up with new ideas for treatments.
But I just have to comment, it is my word of the night. All of this is about power, right? So in people being engaged, sharing their information, registering with the foundation, being a part of Midas, which has this baseline data, gives us, our scientists, the power to go in and find more questions and more data that you need to figure out how do we alleviate some of this hardship of PFTs by doing home spirometry, what's really happening with the menstrual cycle, inhaled sirolimus. These are coming out of patients' questions, and it's kind of Rosie the Riveter is saying, listen to us and help us get through this, and we're making tremendous progress.
That's right. Yeah, it's everything we have that benefits patients in LAM came from patients participating in these studies. Everything, VEGF-D, the effective treatment, the biomarkers we're finding. And actually, while I'm on that topic, I wanted to mention that another thing that single-cell RNA sequencing is going to provide us with is great ideas for new biomarkers. So VEGF-D is a great example of a biomarker that's been saving patients from biopsy now for a decade. We know that if someone has a typical chest CT and their VEGF-D is elevated beyond 800 picograms per mil, that's LAM. Nothing else does that. So that's really been a powerful way to make the diagnosis without having to go to surgery. And if VEGF-D is elevated, we also know that LAM patients with an elevated VEGF-D are more likely to progress and more likely to respond to sirolimus. So it's a good news, bad news thing. But overall, it's a good news thing because we know that we know when to start the drug. VEGF-D is high. That helps us with decision making. And we know from studies that you're more likely to respond if VEGF-D is high. So it's a good biomarker in those two respects. And go ahead, Sue.
No, I was just, go ahead, finish your thought.
Well, the single-cell RNA-seq has suggested dozens and dozens of new biomarkers that we might be looking for in serum that we can investigate one at a time, and we've already found 2 that were suggested by RNA-seq and which are elevated in LAM, and we're looking into how they're going to be useful to us as VEGF-D is useful to us. So that's another tremendously exciting output from this single-cell RNA sequencing data.
So if biomarkers are things we can measure to understand what's happening with the disease, and easier to measure biomarkers make life better. But you talked about blood biomarkers. There are other things that you're hoping we can measure looking forward that will be much easier than a PFT or a lung biopsy. Can you say a little bit about that?
Yeah, so that gets to this imaging issue we were talking about, which is that clinical trials in LAM are difficult because lung function is a messy measurement. It's all dependent on effort that day. If you're having a good day, you might have a good test, and if you're having a crummy day, it might not be so good. And we pay attention to even small variations in those lung function tests. They're not a good endpoint for trials because they have a lot of variability, and that makes trials longer and more expensive, require more people to be involved when there's a lot of variability in the endpoint. So if we had a way to measure LAM cell burden easily, like a PET scan that almost everybody's familiar with, it would greatly accelerate trials and also help us understand who's responding to therapy and who isn't. So just for those who may not know what a PET scan is, and usually used in people with cancer, we inject a radioactive sugar, and cancer cells that are very active take up a lot of that sugar, and they light up when we put a camera over the area of the body where we think that cancer might be. If LAM lit up on a scan like this, we could use it to know where the LAM cells are, how many there are, what the burden is over the entire body, and know when our therapy is hitting the target. We'd see these lights go out, on the PET scan when we're killing LAM cells. So we've been hamstrung by the fact that LAM cells don't really take up a lot of sugar, but they do take up a lot of an amino acid called glutamine. And so a group at Vanderbilt, Lisa Young and Justin Hewitt. Hewitt and Tim Blackwell had put about a year and a half of effort into getting this off the ground, along with Sue at Vanderbilt, and finally got a scan completed on a volunteer LAM patient there. And it looks really promising that LAM cells are taking up this marker and lighting up on the PET scan. And if this is true, we're off to the races with trials in the future, with understanding if LAM patients are responding. It's tremendously exciting, and there's a similar promising imaging technique being developed at the University of California, San Francisco, I think, right, Evans?
Yes, yeah, UCSF.
So he's tagging, he's using gallium, which is another radioactive substance, and which is taken up in a certain situation into LAM cells, and basically lighting them up on a scan that's like a PET scan that may also have promise in LAM. So if this is one of the biggest needs in LAM research, a way to image the lung so that we can do trials faster and understand better when we're effectively treating people.
Great. Light up those LAM cells.
Right.
Yeah. There have been several questions, if you're open to a question now, unless you have another topic that you'd like to speak on first.
No, the question's good.
I think it's a lateral link to the questions about when someone has a hysterectomy, a woman with LAM, does it lessen symptoms? Does it slow progression? Is there any data that shows what the implications of a hysterectomy are?
That is a really good question, and it comes up a lot. We don't have the answer to that question. The NIH is probably the best place to learn it because they've been following patients decades, but it is a messy thing to try to do retrospectively, and it's a very long study to do it prospectively. So I'm a little pessimistic about how likely it is we could answer that question. The way we would have to do it is to be measuring lung function and having a really good idea of lung function trajectory before the uterus was taken out and after it was taken out, and see if there's a difference in the rate of lung function change or decline. And those kinds of data don't exist readily in the general community. It might be able to be done at the NIH, but it's probably going to be difficult to interpret. And there is the horse out of the barn kind of argument too. That is, if LAM has already moved from the uterus to the lung, then taking the uterus out once that's happened may not completely affect the future of LAM in that person. We don't know we don't know if LAM comes from the uterus. We don't know if there's a continuing shower of LAM cells over the lifetime or whether it happens in a period and then stops. So there's so much we don't know about this new information that the uterus might be implicated. But that is I might mention that I've had a few patients in the tuberous sclerosis clinic who have young ladies who have LAM in the uterus and not in the lung. And that's a very vexing situation. What do we do with that situation? Do we take the uterus out in that person, a young person, or do we hope for the best and just follow conservatively? So this has raised a lot of issues.
How do you know if they have LAM in the uterus?
So in this particular person, there was I think some kind of procedure done. I think it was perhaps a DNC-like procedure where LAM cells just appeared unexpectedly in the pathological specimen from that procedure. And this young lady didn't have any cysts in her lung at the time, and the decision was not to take the uterus out. This was over a dozen years ago, and now as an adult, she does have cystic change in her lung. So this is something we're going to have to wrestle with into the future.
But in a normal course of managing a patient with LAM, you typically wouldn't know whether they have LAM cells in their uterus.
No, it's still at a case report level. It's almost every week a case report pops up in the literature about LAM in the uterus, maybe every other week. But we don't go looking for it. It doesn't light up on the PET scan usually. If that patient has a PET scan for another reason, we don't usually see it. And it's microscopic. So even if we have the tissue in our hands, it takes a very careful inspection to find LAM lesions in a uterus. Not like fibroids that are large and easy to see right on the surface of the uterus.
There were a couple of questions about mild and whether mild tracks DLCO decline, and then related to that, is there any progress on drug therapy to slow DLCO decline?
Yeah, that's a good question. The endpoint, the primary endpoint that we're looking at in mild is FEV1 decline. We do have a stop. If your FEV1 declines by a certain amount during the trial, you come out of the trial and you're offered the drug. We tell you whether you were on drug or placebo when we take you out. And that there's a decline in DLCO provision there too. We don't have evidence that sirolimus directly affects the rate of decline in DLCO from the Miles trial, but the NIH published a study a few years ago to say that they felt that there was an effect on slowing rate of decline in DLCO. That was a retrospective study and less powerful than a prospective study, but that data, there is a suggestion that maybe that sirolimus can slow rate of decline in DLCO.
But certainly not everyone's experience.
That's right. I know, and I've seen it myself, that some patients stabilize, the FEV1 stabilizes nicely, and DLCO can continue.
Yeah, very, very frustrating. Jumping back for just a minute to the hysterectomy, interesting question. Are there any studies or questionnaires going on or aimed at those of us who have experience with pathology being confirmed with LAM cells in the ovary or uterus? And is there anything that they can do to help?
So the question is whether in someone who's already has known LAM cells in the uterus or the ovary, although I haven't heard of that. I haven't heard of LAM cells in the ovary. Is there anything known or any studies underway? That's a very unusual situation. There are certainly no studies underway. I'm trying to think how often I've run across that, other than the young lady I told you about with known LAM in her uterus.
So that person should just get in touch with us and tell us how they know.
Yes, and we have a visiting scholar from China who lives in an area with 20 million people, so he has a lot of LAM patients, and I've asked him to go back and find the patients that he has that have had LAM discovered in the uterus that is not yet present in the lung. and he's searching his hospital records for that. And there was a case report of that published this past week, and it's been published. It's been published in the past as well. So it happens, but it's super rare, and I don't have any great insights into what we do in that situation for a patient who was found to have a few LAM cells on a uterine biopsy. We don't know yet. We don't know enough to recommend taking the uterus out in that situation.
All right. Looking to see if there's any that we have not tackled. A lot of related questions. Some concern about LAM returning after transplant, and also a question about any links or studies between LAM and breast cancer.
That's a good question. Both of those are good questions. So I'm skeptical about a link between LAM and breast cancer. There have been a few papers published that suggest there might be one, and there's actually going to be posters at the Lymposium, which talk about patients with LAM who have breast cancer. But breast cancer affects 1 in 7 women, I think. So it's only natural there's going to be a lot of overlap with LAM. No one's ever discovered tuberous sclerosis mutations in the tissue, the breast tissue, as far as I know. So I don't think they would share a common genetic basis. But I don't think there's enough data to know whether there's a link, and I'm very skeptical about it. I don't see why that makes sense. And then the other question was about recurrence and transplant, and that's just to be sure that we're all on the same page there. That's been reported probably a dozen times in the literature and in case reports and in abstracts. It's a rare event. There have been very few cases where it actually threatened the graft. There was, I'm aware of one LAM patient or 2 LAM patients, 3 LAM patients who required sirolimus to control a recurrence in that lung, and which was very effective in the transplanted lung. So we have a strategy if it does happen. It's, as far as I know, no one considers that a contraindication to transplant. Centers don't turn people away because of the possibility LAM will recur that I've ever heard of, and it doesn't usually threaten the graft. So it's taught us a lot about the mechanism of spread in LAM, but I don't think it's had a major impact on outcomes in LAM.
Well, that's good news.
Yeah.
There is good news related to women with LAM and lung transplant.
Yeah, I'm glad you brought that up. So Nishant Gupta and one of our fellows, pulmonary fellows, obtained data from all the lung transplants that have been done from LAM since UNOS has started to collect data. UNOS is the United Network for Organ Sharing. They collect information about all types of transplants. And when they looked at the survival after transplant for patients with LAM, median survival is 12 years. And that's twice what it is for almost all other lung diseases. So, although we don't wish transplant on anyone, in LAM patients, it's more successful than in most any other disease. And I think that's a reflection of the fact that LAM patients are young. They're generally free of other diseases. They often are very attentive to their health and they're fit. And they just do very well with transplant. Whereas patients with cystic fibrosis who've been sick their whole lives have that against them when they go for transplant, and so their survivals are not nearly as good.
Wow. Okay. Well, just to wrap up that previous conversation, we do have some helpful follow-up. This person said they had their ovary removed due to a hemorrhagic ovarian cyst, pathology confirmed LAM. And she's been diagnosed with LAM for 13 years. So there you go, in an ovary.
Yeah.
Yeah.
Interesting.
Yeah. Okay. Well, is there any additional information you could offer related to CT imaging and cyst scores, or some of the MRI studies that are going to be presented at Lymposium? A lot of work going on at the NIH.
At the NIH, and also Nishant Gupta and Chase Hall in Kansas. Dr. Moss is working on very low dose radiation techniques for assessing cysts. And in Kansas and Cincinnati, they're working on methods to quantify cysts.
Very cool.
Yeah, so we can, or they can, perhaps someday take your images from your CAT scan, plug it into an algorithm, and tell you what % of the chest cavity is occupied by cysts, and that can be used to track disease progression or response to therapy. So, if, for instance, you were developing, certain volume of cysts every year before therapy, and then that stabilized and stopped, no new cysts after therapy, that's another good marker to know whether the drug is hitting the target. So those are very necessary and promising techniques for LAM, and those are very close to being useful, I think, or being in the market, being available to us.
Right. More new biomarkers, right?
Yes.
Okay, one final question that I think is pretty straightforward. What are current sirolimus dosage recommendations, or is there a trough level goal?
Yeah, that's a good question also. So the Miles trial was done at a dose of 2 milligrams of sirolimus, and then we titrated the drug to hit a serum level between 5 and 15 nanograms per mil in that trial. But shortly after that study was done, the Japanese did a study where they just treated patients with 1 milligram a day, flat dose, and they had very good outcomes from that, and it worked as well as at least in that open label study as it had in the Miles trial. So we've adopted in Cincinnati, we've adopted a lower dose strategy, given that patients are on this drug for very long periods of time. We want to be sure we're at the lowest effective dose, and almost all of our patients in Cincinnati are on 1 milligram a day. But that isn't the experience everywhere. Many LAM clinics start at 2 milligrams and stay there. Some even higher doses. I don't think we have anybody in Cincinnati on more than 3 milligrams a day, and just a few on 3 milligrams a day. But in other places, and especially when patients seem to be progressing despite therapy, the doses often pushed up to higher levels, and some patients are on even more than 3 milligrams. In our experience, mostly 1 milligram. And we don't really titrate upward to try to maintain a certain serum level. As long as the patient's stable based on serial pulmonary function testing, and we like lots of points. We like to have people that, when we're trying to make decisions about therapy, we like to get spirometry after bronchodilator every 3 months, so that we have tons and tons of points that we can use to be sure we understand rate of decline before and after an intervention's made. So so we only follow the stability of lung function and not so much the serum level. We don't try to target a certain trough level.
Great, very good. Well, I'd like to thank you for your time this evening and a brilliant recovery from some technical difficulties. I think we landed on a great format. I want to thank our 140-ish participants who joined us tonight. We will make this recording available within a week, and we'll also send out a survey and follow up on many of these questions that have come in. I think we got to a lot of them, but not all. And if you'd like to offer any parting words, I would like to thank Mary Sue Wenzel for organizing tonight, as well as the staff at the LAM Foundation for getting this organized and putting Rosie the Riveter back out there in the universe for 80 years. And if you have any parting comments, we'll then sign off and thank everyone. Say good night.
Just wanted to thank everybody for joining. Think about enrolling in MILD, and I hope to see everybody at Lamposium in April.
Yes, an opportunity to ask many more questions.
Yes.
Great. Thank you. Good night, everyone. We'll see you soon.
Bye-bye.
Bye.